Sager. I'm the CEO of Emocha Health. Our mission is to help every patient take every dose of their medication properly. Welcome to Baltimore Innovation Week. Happy to be here once more. I've participated a couple times. This time it's a little bit different than it's been in the past, of course, due to the pandemic, but hopefully that's over soon too. So next year, I hope we're doing this together in person. All right, today I'm going to tell you about a really massive problem in Baltimore, pediatric asthma, which really has been a problem for a very long time. And I hope that today you'll learn a little bit more about that problem. I'll tell you what we're doing to help children in Baltimore with asthma, and I hope that by raising awareness in the next, at the next Baltimore Innovation Week in a year from now, that kids in Baltimore are improving. So we use asynchronous video technology and human engagement to scale a process that comes out of public health. That process is called directly observed therapy. It's when a healthcare worker meets with a patient to help them take their medication properly. It's actually the standard of care all over the world for certain diseases, namely tuberculosis. But thanks to some innovators in Baltimore and in school systems across the country, it's also becoming the standard of care for kids with asthma. Quick overview of the company. We're more than 55 people based out of Baltimore, Maryland, offices in Mount Vernon. We spun out of Johns Hopkins in 2014. We have validated that Emocha's platform can achieve the same results as in-person directly observed therapy. We're now the standard of care in hospitals, at health plans, and in more than 450 health departments all over the country. Here's just a really, really basic overview of how Emocha works. Patients can see their regimen. They then video record themselves and tell us how they're feeling. They then take their medication on that video and submit it to us. And soon thereafter, our team or the provider, the nurse or the patient's physician, will review the video and complete what is an asynchronous video appointment. So patient does their part, and then our team or the provider will send a video back to the patient or send a quick text message back to the patient. The videos can be pre-recorded to save some time in engaging back. But it's a personal and very meaningful experience for the patient, which has been shown to achieve the same results as if there was an in-person meeting. So what you're seeing is actually the next frontier of telehealth, right? You heard a lot about live stream video during the pandemic. Live stream video cuts out travel time. So in theory, a live stream video visit for a patient would be a lot more efficient than an office visit. But asynchronous video visits, meaning the patient and the provider doing an appointment at different times, takes away the scheduling barrier. And really important for patients who can't stream live video because of internet access issues. You don't need to have a great internet connection to participate in your care this way. All right, so now I'm going to tell you, I'm going to spend some time giving you background on asthma. I want to make sure that everybody knows what asthma is and how it affects kids in Baltimore. Many of you may have asthma, so you already know this. And I'm not a doctor, but I have seen the effects of asthma on the patients that we help, and had the chance to work with some great clinicians in Baltimore and all over the country in finding solutions to this problem. So essentially, to put it in the most basic terms, the airways end up swelling due to asthma. There's a overproduction of mucus. Long story short, people with asthma end up during an exacerbation with problems breathing. It's a chronic condition. It doesn't have a cure, but it certainly can be managed. And managing asthma is about both managing triggers for asthma, but there are also incredible medications. It should also be known that the result of an exacerbation of asthma can be really serious and can cost a patient their life. So, and just some basic education here. In terms of the medications, there are generally two kinds. There have been some recent innovations that will combine these medications together, but in general, when patients take their controller medication, which is a daily regimen, it'll prevent exacerbations. But when a patient's already in trouble, then they use a rescue inhaler to quickly stop the swelling in the airways. For kids with moderate to severe asthma, the standard of care is using a controller medication all the time. So what are the big challenges that people with asthma face? Well, of course there are environmental triggers. So this could be it could be pollution, it could be allergens in the air, it could be in their home, it could be that there could be a lot of trash, there could be mold. Getting medication is a problem. There have been some incredible efforts in Baltimore, the Breathmobile, for example, helping get medication to kids. It's often an economic issue. There is also consistent adherence. Taking that controller medication consistently is really, really important. But it's not just important to take the inhaler consistently, it's important to do it correctly. And as it turns out, that is not easy for kids. Finally, there are also the symptoms of asthma, which can be really scary for a child. And then in some communities, there is this attitude that asthma is just par for the course, that you have asthma, your friends have asthma, your parents had asthma, and that there's nothing that you can do about it. So let's put this in numbers. It is known that patients with asthma do not take medication consistently. Across the board, only 50% of medications taken and taken properly. The cost nationally of admissions to hospitals and admissions to emergency rooms tops $50 billion a year. That's astronomical. In Maryland, that cost is $69 million. And here's a figure out from 2019. 11,000 asthma-related emergency room visits were related to pediatric asthma. So kids in Baltimore are ending up in the emergency room at alarming rates. Now, of course, in this number, there were other disease states. If it was only asthma, that's about 3,500 kids every year. Now, this is not a new problem. Here's a headline from 2017 from Kaiser Health News. I actually modified the headline because I found it incorrect. It said that hospitals were responsible entirely for this issue. But the fact of the matter is that this is a known problem. There are zip codes in Baltimore that are disproportionately affected, and those are some of the poorest neighborhoods in the city. Getting into the numbers, I highly encourage you to go to the ABLE Foundation's website and download this incredible study titled The Unequal Burden of Pediatric Asthma, a call for an equity-driven multimodal public health approach to asthma in Baltimore. This was published in October. In the next few slides, we're going to highlight some of the most incredible statistics contained in that report. It's really easy to read, and it's an excellent publication. So kids on Medicaid, and most of you are aware, Medicaid is for persons who economically are typically below the poverty line. 90% of pediatric asthma hospitalizations were kids on Medicaid. And for ED visits, it's about 85% of the kids are on Medicaid. The health disparities are disproportionately affecting children of color, primarily Black and African American kids. So if you're Black in Baltimore, your risk of having an asthma-related emergency room visit is 3 to 5 times higher than your peers. And look at this. This is incredible. If you're in zip code 21223, your risk of ending up in the emergency room is 28 times higher than if you live in 21210. So this has been known for a while as well. And 21223 is down in West Baltimore. These rates, emergency room visits per 1,000 kids, 52, that's like 5% of kids in some of these zip codes are ending up in the emergency room. I consider that completely unacceptable, especially because there are solutions to many of the problems that are faced by kids with asthma. Again, from the Able Foundation's report, things that have to happen in Baltimore in order to reduce this problem. Baltimore's #2 in the country in asthma-related emergency room visits for kids. There is public building remediation needed. There are several community-based programs that get financed any way possible, just from grants here and there, that really send people into kids' homes and help them directly with inhaler technique, to understand whether there are remediations possible, for example, for mold. And there is another solution that I referred to earlier in the presentation called directly observed therapy. The process of helping someone take their medication properly. And as it turns out, school-based directly observed therapy programs are cropping up across the country. And they have been shown to be cost-effective for kids with more severe or moderate asthma. And this has been shown to be a high potential intervention to help kids. Now, often these programs have been found in schools. And, if we go back a couple slides to the comment I made here, asthma hotspots, more profitable to neglect than fix. The fact of the matter is that kids end up in the emergency room or in the hospital when it's too late. The problems that these kids face have solutions in between visits, not at those visits, but in between those visits. So where do you find kids most of the year? You find them in schools. So schools can be a great place to help kids. This is just a photo of Dr. Connor, who runs Project Breathe out of the Rails Health Clinic in a school in West Baltimore. There are several programs, some in New York City. There's one of our partners is in Rochester, New York, where directly observed therapy programs have helped kids learn how to use their inhaler correctly, make sure that they use it on a daily basis, and dramatically reduce the number of kids who are ending up in the emergency room directly out of the classroom, which happens quite a bit. So at Emocha, we have, over time, developed a program to scale directly observed therapy and deliver it almost entirely remotely. We refer to this as our Digital Medication Adherence Program. We surround the patient with a care team, and here you're seeing a real patient. The patient will video record themselves at every dose taking their inhaler, and our team of pharmacists, nurses, and adherence coaches will review that video and get back to the child with suggestions on how to improve the inhaler technique, or congratulations for having done it properly. And what we're going to show you here, so in the previous slide, you saw the patient is video recording themselves. Here's how we see that from our engagement team. I'll just play this awesome video of Elijah. So here's our team going to our engagement portal and playing the video. So Elijah has shaken her medication. That is the proper thing to do with this particular medication. Now she's about to inhale. So she's breathing in the medication and counting off the seconds for how long she needs to hold that breath. And when she's done a great job, we're going to send her a quick video back, letting her know that she did it right. As we'll tell you a little bit in a second about how long it takes to get a child to perform that inhaler technique properly. It's not just an application. We want the child to get involved in their care at a young age. And to do that, we use every single possible tool that we can, including an adherence calendar that comes with some stickers to place on the calendar for every time they take their medication. They get introduced to a real human coach that's going to engage with them for at least the 30 to 90 days of the program. And here's just a quick snapshot of some aggregated data from several of our programs. Proven by LifeBridge Health is that technique issues can be remediated in about 14 days of video-based, directly observed therapy. So what you're seeing here are the different types of technique issues. Most common is holding of breath. That by day 14, these tend to go away. And that's really important because if a child is not using the inhaler correctly, then that incorrect inhaler technique is directly tied to asthma hospitalizations and ED visits in literature. So by learning how to use the inhaler correctly, children will end up, safe at home or in school as opposed to in the emergency room. All right, now back to some numbers. I'm not trying to bomb you with numbers, but they are quite staggering. 94% of patients who have asthma or COPD do not use their inhalers correctly. Of the $50 billion in asthma-related expenditures every year, $6 billion of those are for school-aged kids. And these kids are not just ending up in the emergency room once and then, learning a lesson about taking medication. Over a third of them are right back in the emergency room within a year. That's really, what does that do? It results in not being in school. It's a really scary experience for children and their parents. And in Baltimore City, we've got a really big problem. We're at twice the national average for a diagnosis of asthma in kids, twice the national average. And as mentioned before, 88% of those hospitalizations are Black children. So they're disproportionately affected by uncontrolled asthma. Now, what have we done about it? So we've got an amazing publication that Dr. Krugman from LifeBridge Health presented at a national asthma conference about 2 weeks ago. They offered emocha to children at the clinic up at LifeBridge Health in Mount Washington. 92% of kids offered the program enrolled. Within 14 days, most children resolved inhaler technique issues. But on average, there were 12 errors per child. So many of those they're not unique errors. A lot of them are repeat errors. And what it shows is that using an inhaler, there are some similarities to sport or to other technical challenges that you have to learn over time. You're not just going to tell a child after they've had an emergency room visit how to use an inhaler and expect them to be able to operate the machine. It takes about 2 weeks to 3 weeks for someone to learn the proper technique and get that life-saving medication into their lungs. This isn't anything new, but it really becomes evident when you capture a video of a child using that inhaler every single day. Then you can see, you told them already yesterday, they've repeated the mistake. There's no bad will there. There's no intention. It's just that it's hard to learn how to use these things. Most videos in the first week of the program showed technique issues. So for the purposes of this presentation, we took all of our asthma customers and all videos we've collected, and we started doing asthma. We added asthma to our program about a year ago. So since during this pandemic, we've captured about 6,000 video check-ins from asthma patients, 6,000 videos of kids, but also adults taking their inhaler. And in those 6,000 videos, there have been more than 2,400 challenges detected. Of those, about 900, actually 950, are related to the inhaler technique, or to the administration of the medication, let's say wrong time, in proportion to the meals, et cetera. 600 some we classify as behavioral, meaning forgetfulness or not wanting to take medication. And we've also captured over 800 concerning symptoms, which are, these are important to capture because they are signs that the controller medication is either not having an effect because it's not being inhaled properly or it's not being used. So there is a lot of work to do. And all these video check-ins happen in between visits. So it's not like at hospitals or at clinics, something's going wrong. It's everything in between. And healthcare in this country has to change to help the patient in between these visits. We figured out how to take the in-person visit and make it a live stream visit. That's great. But that's not going to reduce the pediatric asthma problem in Baltimore. We have to help patients in between those visits. What was our pharmacist or nurse or coach doing? What were they correcting? Well, one of the most common corrections was the number of puffs that they take every time they take their medication. There was confusion about that. There are different manufacturers of these inhalers, and each of those, and also the medications, they have different regimens. Some require shaking before use. Others require the patient to cleanse their mouth with water and spit after taking the medication. We captured a lot of symptoms and had to engage back to the patient to make sure they were okay, and deliver extra coaching. And of course, by after day 14, what are we doing? We're congratulating patients who have learned to use their inhaler correctly and are taking it consistently, which is the greatest thing of all once you can see it on video that these kids have learned how to use their inhaler. Their symptoms drop, and they tell you they can breathe. We have some incredible partners here in Baltimore, LifeBridge Health. Actually, we have MedStar as well. We have University of Maryland Health Partners, which is now Care First Community Health Plan. In Rochester, we have a pioneer in directly observed therapy, Dr. Jill Halterman. Rochester has a similar dynamic to Baltimore in terms of health inequities. And we're also proud to have partnered with the American Lung Association. Together with the ALA, we're launching a national program to teach back to children how to correctly use the inhaler. And we're now identifying sites to demonstrate how to partner effectively with a remote intervention. Opportunities here. So in general, school-based directly observed therapy has now been proven effective. It's been proven effective in Baltimore. This was, before the pandemic, and I believe that there has been a report released, or it's about to be released out of Project Breathe. I again point you to the ABLE Foundation's website to download the report by the ABLE Foundation on solutions and also a cost estimate of providing those solutions. We believe that the school-based health center is a great hub for helping kids learn how to use their inhaler correctly. Of course, very few schools have school-based health centers. And in fact, many public schools share nurses across large geographic areas. Emocha can help scale directly observed therapy and enable schools and school nurses to help more children without actually physically being present all the time. And with that, I'll leave you with a nice little clip from the star of the show, Elijah. This was you may have seen this on local news here in Baltimore, but I always find it heartwarming to see Elijah in action, having learned how to use her inhaler and describing how happy she is with both the care she got at LifeBridge, but also the benefits she got out of being able to get the medications that she takes into her lungs. Here we go.
Go to school. Since I've been using it, it changes my breathing because I don't forget, and I take it more, and it helps my breathing.
So with that, we're almost at 4:30. So thank you everybody for having listened in. Please do pay attention to this problem, and we're hopeful that in 1 year we can present a lot more progress for this city. The current status quo is unacceptable. I think we all agree. The health disparities, the race disparities with this problem are not acceptable. And the great news is that there are so many organizations in this city, from the health department to the health plans, to the health systems, to all the community organizations and foundations, that I believe that the willpower is there to take the proven solutions that are already validated and make them a reality and make them available to the 11,000 kids who are ending up in the emergency room every year in this city. Thank you, everybody, and enjoy the rest of Baltimore Innovation Week.